So it is my pleasure to introduce Airee Kim, who will be speaking on yoga therapy and COPD, chronic obstructive pulmonary disease.
Hello, I'll be discussing COPD, chronic obstructive pulmonary disorder. It's a respiratory condition. But before I actually talk about what it is, I want to go into the anatomy and the physiology of it so we can better understand how COPD affects people. So first I'll talk about the anatomy, and then what is it, and then some statistics, and then the Western side of how they treat patients with COPD, and then the yoga therapy side, and then some scientific studies as well. All right, so the respiratory system, the function is to supply the body with oxygen and also to dispose of the carbon dioxide. So the carbon dioxide is actually a waste product produced by our cells after some metabolic activity occurs. And the respiration process is actually composed of 4 different steps, and they all must happen. So the first is pulmonary ventilation, which is just a fancier way of saying breathing. So breathing in air in and out of the lungs. And then the second one is external respiration. This is the gas exchange that happens between the air and the blood. So it's not just us breathing in, there's actually a site of gas exchange that occurs at the alveoli. So alveoli are the little air sacs. They are microscopic. And then there are, and I'm going to show you the slide on the anatomy later, but there are capillaries surrounding all those alveoli, and we have hundreds of millions of them, and that's where the sites of gas exchange occurs. And then the transport of respiratory gases, where oxygen and carbon dioxide are transported between the lungs and the cells of the body. So this is with the help of the cardiovascular system. So as you'll see in a bit, the respiratory system and the cardiovascular system are intimately linked. And then the last is the internal respiration. So the gases that have already come into the lungs through external respiration are exchanged between the blood and tissue cells. So for example, your skeletal muscles. All right, so I already mentioned that they're intimately linked, and then we'll see later that there are some cardiovascular issues that can arise for people who have COPD. So functional anatomy, the respiratory system is separated into 2 zones, the conducting zone and the respiratory zone. So the conducting zone includes the respiratory passageways that carry air to the sites of gas exchange. So the alveoli, the respiratory passageways, which actually include the nose, the nasal cavity, your trachea, and then the conducting zone, its function is to warm, moisten, and filter the inhaled air. And then the respiratory zone is the actual site of gas exchange in the lungs. So those are going to be your bronchioles, your alveoli. And I'm not going to go through all of these in detail because it's a lot, but there are a lot of different parts to the respiratory system, and the only external part of the respiratory system is going to be the nose. And then, so all the way to the alveoli. So it basically starts from the nose, and then the alveoli is where it ends. I have a little picture. The pharynx is the throat. It is the passageway for both food and air. And as you may know, when we swallow, the epiglottis folds down, so it doesn't go through the wrong way. And then the trachea is a windpipe. That's where the air will flow. So now the microscopic view of the respiratory system. So the right lung is divided into 3 lobes. The left lung is divided into 2. And because the heart is tilted slightly to the left, that's why you see on the left lung it's shaped like that. And in box B, when I mentioned earlier that the alveoli are surrounded by the capillaries, you can see just how many of those tiny blood vessels are surrounding it. So the oxygen comes in, and then the carbon dioxide comes out. But in box C, you can see that this is where the diffusion happens. So it's going to be simple diffusion. I'm getting kind of technical about it because I took anatomy. But yeah, simple diffusion is a form of passive diffusion. So no energy is being spent. So yeah. Oh, and fun fact, we have about 300 million of these little alveoli. And then if we were to spread them all out, it would span about 1,500 square feet. And it's actually more surface area than our skin. I thought that was really interesting. Okay, ventilation, just breathing. As you know, inspiration, expiration, inhaling and exhaling. So the muscles that are involved for inhaling and exhaling are the same. It's just that in inspiration, the muscles are contracted, and then in expiration, they're just relaxed. So the diaphragm, it's first a dome shaped when it's relaxed, and then when we inhale, it contracts, and then it flattens downwards. And then it functions to increase the volume of the thorax, which is the area or the region between our neck and our abdomen. And the external intercostal muscles also help with this as well. The intercostal muscles are the muscles that run in between the ribs. And for the external intercostals, they lift the ribs so that the thoracic cavity enlarges laterally and anteriorly and posteriorly. In the next photo, I won't go too much into this, but this is interesting how the vagus nerve, the 10th cranial nerve, the only cranial nerve that extends further down into the body, innervates tons of organs, the lungs, the heart. And just something that I found online, the vagal parasympathetic pathways mediate both contraction and relaxation of the tracheobronchial smooth muscle. So the trachea, the windpipe, the bronchial, the air passageways. Okay, now what is COPD? Chronic obstructive pulmonary disorder. So chronic because it's pretty much throughout the lifetime, not acute. Obstructive because the breathing is impacted. And pulmonary means lung. So it's really just an umbrella term for emphysema and chronic bronchitis. So if someone has either one of those, they're going to be diagnosed with COPD. And then the standard definition, chronic inflammatory lung disease causing limited obstructed airflow in and out of the lungs, which is just less oxygen coming in and less carbon dioxide leaving the body. It is progressive and currently incurable, but preventable and manageable. All right, so first I'm going to talk about emphysema. So this is a deterioration and permanent enlargement of the alveoli in the lungs, those little air sacs. So I'm going to skip to the picture here that I found. As you can see that there's disintegration there in the alveoli, so there is going to be less opportunity for the most efficient optimal gas exchange to happen. And yeah, less oxygen to the bloodstream. So when we inhale, the alveoli expands. And then when we exhale, it recoils back. That's what the elastic recoil or the elasticity means. But for people who have emphysema, basically it's just always enlarged. So it's not going to be as efficient to bring in oxygen. And with emphysema, we'll see a barrel chest. And I'll go to this picture here. This is a person with a normal chest, this person with a barrel chest. And you might already have seen this if you have worked with patients who have COPD. So they have overdeveloped chest muscles because they can't breathe normally. And you'll also see a flattening of the diaphragm. So earlier when I said in its normal state, when you're not inhaling and exhaling, or when you're not inhaling, it's domed. But here you see more flattening already, so that already decreases your breathing efficiency. And earlier when I said that the cardiovascular and respiratory system are intimately linked, there are cardiovascular issues that may arise. There are more issues than this, the right ventricle of the heart enlarging, but I didn't include everything. This is just one example. And the reason why the right ventricle might enlarge is because there's not enough oxygen coming into the blood. The right ventricle would be pumping harder to try to get as much oxygen flowing to the rest of the body as much as it can. And at the top, you'll see the normal alveoli, so it's nice and spherical, but then someone with emphysema will have those damaged alveoli. Couldn't find I only found an animated picture, but I still think that shows pretty well. Okay, chronic bronchitis. So the symptoms of emphysema and chronic bronchitis are the same, but the way that it affects the body, like anatomically, physiologically, are different. So with chronic bronchitis, it affects the lining of the bronchial tubes in the lungs, so those air passageways. Cilia get damaged. So cilia are these little tiny microscopic hairs that are present in several parts of the body, but in this case, in our trachea. So they get damaged and they cannot effectively sweep mucus upwards. That's their job, to take out dirt, debris, excess mucus. And infections are common, and that's probably because of that excess mucus. It's a pretty good home for bacteria and such. And this picture to the left shows a normal lung, which is nice and open. And then the right, you can see that it's inflamed, and so the opening isn't as large, lots of mucus there. All right, so symptoms are going to be the same. Dyspnea, just fancier word for saying bad breathing, shortness of breath, coughing, wheezing, tightness in the chest, lack of energy. And cyanosis, you'll see that more common with chronic bronchitis. It's like a bluish discoloration of the skin. And that's because of inadequate oxygen, oxygenation of the blood, and poor circulation. Causes. Number one, hands down, smoking cigarettes. So no matter who I asked, wherever I read. So if they're a current smoker, first thing is to get them to stop smoking. Also secondhand smoke, air pollution, so chemical fumes, dust, even like coal workers, coal miners, you'll see that they have them too. And more rare is genes. So a rare inherited condition called alpha-1 antitrypsin deficiency. So they're not able to produce as much alpha-1 protein, which is produced by the liver. And that protein helps protect the lungs by preventing them from getting broken down. Statistics. I couldn't find a more recent one, but even 4 years ago, this was the third leading cause of death in the US. And I did not know that. That was very surprising to me. And then 15.7 million Americans diagnosed. And this is Americans. I didn't even look at the global statistics. And for some reason, the rates are highest in the Southeast and Midwest. I didn't look into why, but For some reason, that's what the statistics are. And then more than 50% of adults with low pulmonary function were unaware that they had it. So it's a possibility that more people have it. It's just maybe they just don't have insurance, or maybe they didn't think to talk to their doctor about it or something. Okay, who has it? Mostly diagnosed when they're over 65 years old, but also pretty equal prevalence between males and females, and definitely current and former smokers, history of asthma, and for both emphysema and chronic bronchitis, more common in non-Hispanic whites. All right, so these are some of the medical interventions that I've researched. Of course, number one, stop smoking if you're already smoking. And then medications, there are more than what I listed, but these are just the main ones. Bronchodilators relax the muscles around the airways. They usually come in the form of inhalers, so they help relieve coughing, shortness of breath, to make breathing easier. There are short-acting and long-acting versions. And then inhaled steroids, there are also oral steroids, but those tend to have more side effects. They reduce the inflammation. Next are lung therapies, oxygen therapy, so just providing supplemental oxygen, and pulmonary rehabilitation programs. So I guess you could think of this as like a holistic way, providing them education, counseling, exercise training. And then the last leg, surgery, which of course when the meds don't help, and we hope that it will be the last, absolute last resort. Lung transplant, lung volume reduction, so removing the damaged lung tissue from the upper lungs. So this helps to create extra space in the chest cavity so that the remaining healthy lung tissue has room to expand. And then bulectomy, bullae are the large air spaces that form when the air sacs are destroyed. So earlier when I mentioned that the alveoli get enlarged, they stay enlarged, so they're removed to improve airflow also. Okay, so specifically I interviewed an EMT, emergency medical technician, and an MD. So from an EMT perspective, pretty much the same that I've mentioned a few slides ago. So he listens to lungs to hear wheezing. Then he administers oxygen via a non-rebreather mask, looks like that. And then he monitors the patient, and if needed, gives bronchodilators. And as a last resort, corticosteroids, or a CPAP device that looks like this. So CPAP stands for continuous positive airway pressure. So it has a fan inside that draws air in and then gently pressurizes it, and then delivers it at a setting specific to the person's needs. From an MD, I interviewed Dr. Spar from the Venice Family Clinic, and I'm really grateful that it was an email interview, but granted, I'm still very grateful that I was able to speak with him because, as some of you know, he's a different type of MD. So, I mean, you can already see he has all these, non-conventional, non-Western, really. So if the person is still a smoker, again, primary goal is to have them quit. And smoking cigarettes, of course, is very tough the longer they smoke. So he suggested different ways to help them quit if they're having trouble. Acupuncture, hypnosis, relaxation techniques, yoga, I guess, falls in that category too. And cupping can help with symptoms. I didn't know that. And he also suggested detoxification. Glutathione and acetylcysteine are both antioxidants, and you can find them online in the stores. You can buy them as a supplement. They're both antioxidants. I looked up N-acetylcysteine online and to see what the benefits were. And it says it supports healthy respiratory function and supports detoxification of environmental toxins and pollutants. So it's literally for this. And foods with sulforaphane, I had no idea what that was either, but it's disease fighting. And broccoli sprouts are a very good source of that. Bok choy, kale, cauliflower, and tons of other foods that you probably already eat. All right, so the yoga therapy side, I also interviewed Tara Gold. And she suggested to inform the patients of the 5 kosha model. And it's, not just for patients with respiratory conditions, but for anyone we work with. But why? Why is that important to let them know what our method is? To educate them, to have them be on the same roadmap as us, and to increase compliance too. So Anamaya, physical body, it includes things like range of motion, strength, balance, stability. Pranamaya, the bioenergetic body, so your breath, energy level. Manomaya, the emotional body, includes your stress level, emotional status, self-esteem. Vijnanamaya, intellectual body, characterized by discernment. Intuitive sense as to why they are experiencing what they're experiencing and what it means to them. And then Anandamaya, a spiritual body, so their life purpose, their connection to the divine, relationships, their life purpose. And the asana, so you have some chest opening to help them to feel more space here. So, like wing prayer would be like an example, maybe like a newspaper, or like, hands behind back. It could be standing or seated. It really just depends on what the patient is able to do. So it's not really a one-size-fits-all. Anything that promotes lower extremity stability and upper extremity lightness opening. So maybe like a standing Tadasana with a little bit of a back bend in the arms in a U position, something like that. And I asked her, is there an optimal position for breathing with COPD patients? And she said, yeah, angled on a wedge or seated. And she said that she would like to push their limit little by little. Asana, pranayama, because she does want to see them improve, push their boundaries a little bit. So a few different breathing techniques is to slow down the exhalation, is to help control those muscles of exhalation when normally we think that exhalation to be passive. We can help give the patients feeling a little bit more of control. And pursed lip breathing, it may help people increase the exhalation time, resulting in the reduction of respiratory rate, thus breathing more deeply. So I actually had, my case study was from the Venice Family Clinic, and I had about 6 sessions with him. He had COPD, but also a number of other conditions which made it very complex, multiple myeloma, frozen shoulder. And so I was trying to work with all of these things at once, but definitely with the chest opening, the pursed lip breathing. So basically it would look like this. So instead of like just through the nose, which may be harder for them, they did pursed lip. And then inhaling and exhale with little puffs. So like this. Like that. And then the last thing that Tara mentioned was to vocalize on the exhale. So she likes to use the words or s. And she said if they can to have the arms in a U position. And she said this is great because the scapula, the shoulder blades are set correctly on the back. But only if they can. in terms of my patient, the patient that I worked with, he wasn't able to do this because his left shoulder was frozen. So, as far as it could go here and then just a little bit here, but still, it was something. And the most important thing is that they regulate their nervous system, find steadiness, give them a sense of control. Contraindications? Not much. Of course, taking breaks as needed, monitoring them. Not having them in the prone position, meaning having them on their belly on the ground because it will restrict their diaphragm. They're already restricted in that area. All right, lastly are the scientific studies. So I only included one on these slides, but I can talk about the others. This one, HRQL stands for Health-Related Quality of Life. And this studied the effects of Iyengar yoga. And I don't really know much about Iyengar yoga, so I did a quick search. And what the internet said was that they focus on the asana first, and then when the students have a little bit more mastery of that, then they get to the pranayama, which I thought, oh, that's interesting. I thought I would want to maybe do the breathing first, especially with people's respiratory conditions. So this was 2-hour bi-weekly for 12 weeks, and this was not yoga therapy. This was pretty much like a one-size-fits-all. Had a certain set of poses. There were 13 poses, and so some examples were supported corpse pose, which I liked, bridge pose, seated forward fold, Janu Shirshasana, the head to knee pose, Baddha Konasana, the bound angle pose. Those were just some examples. Small sample size. There were only about 16. That's pretty small. So assessment, 6MWD, that stands for 6-minute walking distance. This test measures how far a patient can walk at their own pace in 6 minutes, which quantifies functional mobility. CRQ is a chronic respiratory questionnaire. It is a health-related quality of life measure. So as someone mentioned earlier, there are tons of questionnaires out there. This one is specific to the respiratory. HADS for mental health issues. So there are comorbidities with anxiety, depression, and then HUI is for general function and well-being, such as vision, dexterity, cognition, emotion. And what I liked about this study is that they had the patients write journal entries. So after every session, they will write about the poses or how they felt about the practice afterwards. Results. Statistically significant in the average CRQ fatigue, because they do get fatigued often, and the anxiety scores. Statistically significant, okay. So there are tests that measure this. So 2 examples are ANOVA and t-test. And basically you find a p-value. And if the p-value is less than 0.05, that means it's statistically significant. Well, what that means is that the results were probably not due to error or chance. And in the scientific community, we're not going to say, this was definitely a result of this, but we can say that it has a strong correlation, so it was statistically significant. 3 things found in journals. I really like this. They found some things: body awareness, emotional state, physical effect, their energy, their openness. And I think just in and of itself, that is already a huge step. Okay, I think that's the last one. Yeah. But okay, so I'll talk about some of the other studies, 2 more studies. One is called Effects of Controlled Breathing Exercises and Respiratory Muscle Training in People with COPD. So this wasn't an actual scientific study, but it reviewed evidence of 7 systematic reviews about breathing control exercises and respiratory muscle training. So in terms of the breathing control exercises, there was diaphragmatic breathing, the pursed-lip breathing that I mentioned earlier, relaxation techniques, and body position exercises. So positions that, as even Tara mentioned before, positions that relax the upper chest, shoulders, and arms. And then respiratory muscle training to improve muscle strength and endurance. There wasn't too much conclusive evidence. I mean, they ended up reviewing 7, but out of a pool of reviews, there were only a few, maybe like 2 or 3 high-quality reviews, and a few medium quality and a few lower quality. So the 7 really was just more of the higher and the mid-quality studies. And one study found that 40% of dyspnea, the bad breathing, was relieved with the pursed-lip breathing. And the diaphragmatic breathing showed effects in only 1 study. And then the last article that I'll talk about is not so much a study, but, well, okay. It's called Preference for 6 Different Relaxation Techniques by COPD Patients. So this was done with 20 hospital inpatients in the UK. And what they did was, okay, so the 6 different techniques used were counting 1 to 5 repeatedly. Second was repeat a meaningless word, but only associate that word with relaxation. The third was progressive muscle relaxation. So it was kind of like a meditation too, but basically they clenched a certain area of the body and then relaxed it. So they can sense what it's like to feel tense and then what it's like to feel relaxed. Positive emotion imagery. Basically what they did with that is to have them imagine a ball of light and to have that ball of light enter their body or surround their body with happiness and joy. And the next is body movement, so like asanas. And the last one was nice place imagery. So what we know as bhavana, positive visualization. And what they did was to switch up the order in which they presented all 6 of these to each of the 20 patients because they wanted to reduce order effects. So in psychology, I believe there's an effect where if you give someone a list of something, they might prefer something that's early on in the list or later on in the list. So they mixed up the order in which they gave it to the patient because they wanted to reduce that. And what they found was that the first that ranked most effective was the nice place imagery. And most likely to do at home. So they had patients rank both. So which one worked best for them and which one did they like the most and where they would do it at home. Because that's the most important thing, to continue self-care and regulation at home. The second most popular was the progressive muscle relaxation. And I picked this study out to talk about with you all is because, I mean, I think this relates to yoga therapy, right? Because this is asking the patients what works for them and what doesn't. And because, compared to this Iyengar study, which just gave them a set of poses to do, well, it's not going to work for everyone. But this relates to the yoga therapy because we're asking them what their preference is, what works for them, and of course, it would probably increase compliance to partake in things that they actually enjoy. Yeah, that's all. Thank you.